Good morning, everyone, and a very warm thanks to the Lancet for making this possible, and indeed the Gates Foundation, but particularly to the London School for hosting this event today. It's wonderful to see so many people filling the room today and from so very many backgrounds. I think when you talk to each other over the lunch break, you'll find all sorts of different kinds of people in the room from different organisations. It's my privilege and honour to be here to open up, if you like, this series on behalf of all the series authors, many of whom are in the room. You'll find them with little yellow highlights on their badges, so if you're sitting beside somebody or talking to somebody with a yellow highlight, they're a series author. Do talk to them. My job this morning is to tell you about our journey that started well over 3 years ago and that's culminated today in this amazing front cover to the Lancet. Midwifery, it says, is a vital solution to the challenges of providing high quality maternal and newborn care for all women and infants in all countries. Now that looks as if we've got that sorted. We found the answer. But actually, my job this morning is to tell you that actually our journey was one of questions, of disputes, of disagreements, of challenges, of gradually working through how to bring light into an area where there is often so much heat, but that matters incredibly to women, babies, families, and communities across the world. This series developed and grew its roots from conversations that I think, because I wasn't there, swirled around in the run-up to the State of the World's Midwifery 2011. And there were key individuals and agencies involved in those conversations, several of whom are actually in the room. Petra and Jim Campbell from Integrari, the World Health Organization, the Lancet, the International Confederation of Midwives, and many others. And there came if you like, a realisation, I believe Zoe Mullen from the Lancet, also part of those conversations, that such a thing would do some good. And the Bill and Melinda Gates Foundation funded the series and our work began. It sprang out of a recognition that midwifery matters. It matters hugely and has the potential to contribute to much more. But evidence is needed, if you like, to inform decision makers, not all of whom will know that by any means, or who may have other information to counter that. And we wanted to answer a whole lot of core questions, some of which look very basic and straightforward and may seem to you to be absolutely simple to answer. What is midwifery, for example? Actually, the more we looked at these questions, the more you look at something, the less it goes into focus. It kind of swirls out of focus and then back in again and out again and in again. That's what happened to us with these questions. 1 minute we thought we had the answer, and then suddenly we realised we hadn't done quite enough. We're also situating the series, and the conversations at the time were about situating it in the wider context of global developments. These are some of the current global developments that we have considered on the way through, how midwifery can contribute, and of course the State of the World's Midwifery report that was launched in Prague just a couple of weeks ago is another such development. We encountered a number of challenges. I'm going to tell you some of the key ones so you can understand a bit why the series is the shape it is and why we did the kind of work that we did to answer what some people think is a pretty simple question. There are a number of different perspectives to consider, and we wanted to look at midwifery globally because women having babies, a woman having a baby in Bangladesh is not that different in her needs from a woman having a baby in London or in California or in Rio de Janeiro. So we wanted to look at those needs of women and babies globally. We encountered different dialogues, people with different particular core focus interests in reducing mortality versus improving health and well-being. Some people have dedicated their lives to reducing mortality for women and babies. Others are working really hard on quality. We wanted to think of both perspectives. Some people focus more on the woman or the infant. Again, we saw those as indivisible. And we needed in these different dialogues to develop shared understanding and consensus across disciplines and across organisations. Building consensus as we went was a very clear part of what we were aiming to do. Powerful as the Lancet is, it can't make change on its own, and we wanted the key organisations in the field to really be with us. Another challenge, and it's one that will come up right through the day and right through any discourse on this series, is the range of caregivers who we have to consider in terms of providing midwifery. Those, of course, are midwives. Across the world, there are many settings in which there are no midwives or not enough midwives, or many others are involved in the care of women. Those are skilled birth attendants of different sorts. They could be community health workers, they could be nurses, they could be doctors, they could be a range of other backgrounds. We wanted to speak to all of them, and you'll see in a moment how we have worked to do that. There is, of course, an overlap in many of those roles and a different range of responsibilities in different settings and different health systems, and we didn't want to exclude any mother and baby from our consideration. There are specifically, and Zoe's already alluded to this, a number of barriers to midwives. We did a pretty systematic search of the literature, so what I'm about to tell you comes from the literature and not just our experience and views. Midwives are disempowered or overlooked in many contexts. There are inconsistent standards of education and regulation. Midwives in many contexts are limited in what they can do, even if they have the competencies, the skills and experience. They may not be allowed to practice to their full scope. In many countries there is a low status of women, and midwives are predominantly, although not entirely, women, and so encounter that themselves. And in many settings there will be inadequate remuneration for midwife skills, or indeed even risk to their well-being and their own safety. Then, of course, the evidence base is limited. We were determined that whatever we said with force and with conviction was evidence-based, and that we could assure ourselves and everyone else of that. But of course, the evidence is limited in some regards, particularly around midwifery in low and middle income countries, inadequate quality of some routine data, even looking for coverage of midwives. Richard wanted us to draw a map of the coverage of midwifery and midwives and others practicing midwifery globally. We couldn't do it. It would not have been good enough quality because of the inadequate quality. There's often a focus on very specific individual interventions as opposed to the whole package of care that mothers and babies need. In the literature, the components of experimental and control groups in many trials are not well described. They don't distinguish between what's being done, how it's being done, and who's doing it. A wide range of short, medium, and long-term outcomes are not measured. There's often a core focus on very short-term clinical outcomes. So how did we do this? We brought together a brilliant group of around 35 people from 5 continents. I tried to count up the number of countries and I ran out at 18, but I think it's a little more than that. They're from all of those backgrounds. I'm not going to read them out, but you'll see for yourself they stretch right across the relevant disciplinary spectrum, research disciplines and clinical disciplines alike. We had a whole lot of input and help from close readers and critical friends, sometimes more critical than friends. However, I think we're still all friends because we got through it and they made us much better, as indeed did those other fantastic organisations who were unstinting in their input and help. And a particular thanks to the Lancet editors and reviewers who really sharpened us up no end. Our response to all of those challenges is this. The series focuses absolutely front, middle and back on the needs of women, infants and families. It's all based on a human rights-based approach that all women and all children need high quality care. It draws on very, very diverse sources of evidence. We go from qualitative research through to systematic reviews of randomized controlled trials, modelling and detailed health system analysis. We have tried to scope in all relevant outcomes, survival and health and well-being. We have tried to be relevant to low, middle and high income settings, take a long-term view on quality care and services and not reach for the low-hanging fruit and the quick fixes. We've taken an interdisciplinary cross-sectoral health systems perspective, acknowledging the diverse workforce and the importance of integration into the health system in an interdisciplinary way. And we have examined the specific context or contribution of midwives. So no, this is not a professionalising project, neither is it a separatist project, but its findings do place midwifery and midwives in their evidence-based place in the landscape of maternal and newborn care, which is right in the middle, right beside mothers and babies, wherever they are. This may not be the series that many expect. We believe it is the series that we need at this point in time, and we look forward to your views and the discussion afterwards. We learned that we needed to ask different questions to start from a different perspective, and that's what we've done today, and that's what we're going to introduce you to this morning. Thank you very much.